been an amazing symposium so far. So just and thanks for the invitation. So just to also acknowledge the fact that I'm an HIV doctor, and I'm used to looking after skinny people, and now I'm dealing with the fact that my clinic actually looks more like a type 2 diabetic clinic, and it's this existential weirdness in HIV that the major clinical problem in HIV is obesity. And I don't think maybe everybody on the call on the symposium actually understands that opportunistic infections are important, and that's probably what some of you deal with still with late presentations. But for the average HIV patients, that's long gone. Like the last 3 or 4 years, this is what we deal with. It was with obesity. I'm going to just talk about that very quickly. These are my various disclosures. So you all have grown up in the period of antiretrovirals, of tenofovir and efavirenz. A few of you will remember the bad old days of D4T, which kept you skinny in a really horrible way. But we've graduated from tenofovir to efavirenz, and now we're sitting in an era with dolutegravir, and there's no more second line, there's no more third line, there's nothing. Dolutegravir is so potent that it's made antiretroviral therapy really, really boring. And in fact, it's made the whole field of HIV really boring. It doesn't even have any decent drug-drug interactions. In fact, people like me barely have a job left anymore because of dolutegravir, because it's next to impossible to develop resistance. All you have to do is, if somebody gets the viral load goes up, well, the only explanation really is they're not swallowing their tablets. So there's no resistance, there's no real toxicity associated with the drugs. So we've got to the stage where for the average physician, for the average doctor, for the average nurse, HIV is becoming really simple. It's not that it's not a problem. There's still a hang of a lot of people with HIV, still lots of people getting HIV. But the actual therapeutics are becoming so simple. It's the context around them that is becoming the hard stuff. So we're moving to a field where we get in the long-acting injectables, and you all need to just keep an eye on that. But that'll start evolving in the next 3 to 5 years. But for the next few years, this is the combination you're looking at. And I'm going to talk a little bit about what's happening around this. People are also just getting older and older, and South Africans who go on to antiretrovirals, as long as they start at a decent CD4 count over 350, as long as they take their tablets, their life expectancy is pretty much the same as other South Africans. In some of the richer countries, if you start your with a good CD4 count, you actually live longer than the general population. That's probably just because you're getting your flu vaccines and you're told to stop smoking and all the other stuff. But even in places like Uganda, you live longer if you're in an HIV program than the general population. I got told I must be careful about showing slides like this because everyone thinks these people are HIV positive. But the thing about HIV positive people is they get returned, in South Africa, is they get returned, they become like the average South African. And the average South African, as everybody has said in the previous talks, is overweight. And they get returned into this obesogenic environment. And it's absolutely no surprise that once you get onto antiretrovirals, you start gaining weight. Now, in it's quite hard to bring across to people not involved in the HIV world how quickly the world has pivoted since 2019. In early 2019, Andy Hill, who I work with very closely, generated this article about antiretrovirals causing weight gain. Now, we're fairly clear now they probably don't. So just file that in the back of your head. But I remember when he brought out this article with these 2 other very famous HIVologists in England, being quite irritated, like I stopped creating drama, in the HIV world. We've got enough drama. HIV needs like a drama a year, and we just had enough of this now. And he brought out this paper showing that there was significant weight gain with all the new antiretrovirals. So, and it's hard to understand, like, why would antiretrovirals cause weight gain? And I'll show you why in just a moment. Now, this article came out in a newish journal right at the start of 2019. It actually came out as an e-publication at the end of 2018, caused a bit of a ripple, and came at the back of another article that came out in 2018 that showed in this German study, and then also in another Dutch study that showed patients switching from a new form of to a new form of tenofovir, that patients started to gain weight. In fact, so this is the very first study that demonstrated that patients actually turn around and say to their doctors, hey, I'm not happy with this new regimen, we're gaining weight. And this triggered a whole range of things, including a special thing. That CROI is this big American HIV conference that happens every February in the States. And they had a special thing at the start of 2019 on weight gain in HIV on ARVs. And they suddenly started having this theme discussion, the whole session on this, which demonstrated a whole range of abstracts. But this abstract showed that women seem to be gaining weight more than men, and that Black people seem to be gaining weight more than white people on antiretroviral therapy. So lots of drama, lots of like, oh my God, what's going on here? Paul Sachs, who's many of you might have heard of, he's this very famous Harvard infectious diseases guy, very sweet bloke, put out this this synthesized meta-analysis of all modern antiretroviral studies run by one of the big ARV drug companies, Gilead, who many of you might know from COVID days for one of their drugs, remdesivir, who did a meta-analysis of all their drugs and then looked at who gained weight. And a lot of these drug companies never declared the weight gain at the time, but he went and pulled all the original data and showed that people who started ARVs who were very advanced, low CD4 counts, high viral loads, gained the most weight. Now you might say, well, obviously, they were more advanced, so they gained more weight. But even, with sort of intermediate CD4 counts, like 250, 300, where they haven't lost that much weight, they gained more weight than, say, somebody with a CD4 count of 500. And again, he showed that if you're a woman or if you were Black, you gain more weight. He also showed that with the newer agents, particularly bictegravir and dolutegravir, the two new integrated inhibitors, and they're pretty much exactly the same, as well as drugs like rilpivirine, which is a better form of efavirenz, and a new form, and some of the newer forms of tenofovir, TAF, they seem to gain more weight. Another big study, which was a switch study where they switched them to the newer ARVs, again, a study called OPERA, they showed that when you switched across to any of the new drugs in any combination, people gained a significant amount of weight. So again, it seemed everyone's saying, oh dear, these new drugs make you gain weight. So by about April, May of 2019, so obviously 2019 is very important to all of us because it's all pre-COVID. This is where HIV land had landed. We decided if you have advanced disease, or if you were put onto dolutegravir or bictegravir, as I said, it's the other form of dolutegravir, or this new tenofovir, TAF, or if you were put onto a protease inhibitor or rilpivirine, or if you're a woman, or if you're Black, you were going to gain weight. If you were given tenofovir or efavirenz, it seemed to blunt the weight gain, or it even made you lose weight. And this is where we sat. So why did we miss this for the last 20 years? Well, mainly it seems we put out the study, we went and pulled all the new studies, and it seems like it's mainly because they test these drugs on middle class or even rich white gay men in North America and Europe. They don't test them on the people who actually swallow the tablets in most of the world. Even if you apply it to America and Europe, they don't apply to those populations who actually swallow those tablets. So it's grossly overrepresentative of those groups of people. And this is why they probably missed these toxicity signals. And it's a very instructive, important lesson for us in Southern Africa. So the study that made my unit famous was a study called ADVANCE, which I'd love to tell you was all about weight gain, but we didn't have a clue that this was on the horizon when we designed it in 2015, 2016. We ran the study out of a little shack in Yeovil. So for those of you who want to become famous running studies, you can do it with very, very few resources. We did it at a fraction of the cost of what these studies normally cost, these big drug study. And we tested the regimen, which you're all probably familiar with, which South Africa and most of the world was using, in fact, there in the bottom box a couple of years ago, to the current regimen, which is the middle box there, to the regimen which most of the world is in the rich countries, America and Europe and some of South America are using in the top box there. I'm not going to go into details. If you know what they are, you'll know what they are. And if you don't, I really wouldn't bother. But most of your patients in the public sector are going to be in that middle box. And in the private sector, in fact, most of the patients are going to be in the bottom box, and a few of them are going to be in the middle box. And hopefully in the future, they'll all be in the middle box and some of them in the top box. So we ran the study of essentially of Yeovil recruiting patients from Hillbrow. And what we showed, all three regimens worked like a bomb. They were brilliant. But what we showed was this incredible weight gain. This freaked everybody out, not just in women, but in men, but was really in women over 2 years. As you can see in the top regimen, women gained an average of 10 kilograms just in the first 2 years. And these were actually patients with relatively preserved CD4 counts of around 350. Now we're now about to publish the 4-year data. We're submitting to the Lancet. And this data is a straight line for men. It's a straight line for women. 80% of the women are obese after 5 years. We've actually got some of the patients who exited the study are going into 6 years now. But even the men, most of them are ending up obese after a couple of years. So it's really staggering how much weight people are gaining. A concurrent study was done in Cameroon. We published in called Namsal. We published Advance with Namsal in the journals at exactly the same time. And I think that's why people were quite freaked out, is that this was data in two separate, very, very separate environments, Cameroon and South Africa, showing exactly the same thing. And again, they showed significant weight gain, in fact, very similar weight gain. The study design was quite different. We had a lot more toxicity monitoring, and we had DEXA data in Johannesburg. They didn't have it in Namsal, but they showed very similar weight gain. What we did demonstrate, which I didn't mention earlier, is that we didn't show any change. You're going to ask this, I suspect, in question time. We didn't show lipid changes. We didn't show any significant glucose changes. Didn't show blood pressure changes. They just gained weight. And that's really important because I'm not sure what to make of that, you know, and it's only 2-year data, but we're out to 4-year data. And I can tell you that there's tiny change in glucose. There's a tiny, tiny change in lipids, but nothing that's clinically significant yet. They're just really ballooning in a way that is alarming, but there's nothing metabolic that's happening yet. We haven't looked at their livers for NASH. We haven't done any of the other stuff that Pravin was talking about. And I'm sure the stuff Didi and Adam and others are going to be really worried about. We really do need to start looking at that stuff, but the sort of blood taking that we're doing, we're not seeing stuff. So we've got lots and lots of questions about this. Are the ARVs causing harm? And until Gary Martins in Cape Town did a really nifty study, people were saying, are the drugs making you fat? And I think that the majority of the HIV world now thinks actually this is not what's happening. We think they're actually just turning back into South Africans. We don't think the drugs are making them fat. We think tenofovir and efavirenz cause them to remain thin. And I'll show you why in just a moment. However, if it was the drugs that were making them, that there was some bizarre multiple off-target metabolic like sort of off-target toxicities that were causing it, we can see lots of non-inferiority studies being done, including some here in Johannesburg we're doing with new ARVs. I don't think they're going to show any benefits, I must be honest, or if they are, they're going to be mild changes. So trying to find new ARV regimens to keep you thin, I think, is hiding to nowhere. If there's no change, we're going to see absolutely nothing. That everybody is just going to get fat, doesn't matter which ARV regimen you use. And it is absolutely imperative that we start demanding that these studies get done in our local populations. I've said here black women, but I actually just mean everybody, because we're seeing, even amongst black men, we're seeing this real obesity epidemic. So Gary did this amazing little study. We took the advanced patients and he looked at slow metabolizers and fast metabolizers and efavirenz. And we see this particularly in black populations. And he's shown very categorically that efavirenz does cause a form of lipoatrophy, that slow metabolizers, the patients who get neurotoxicity, who get hepatotoxicity with efavirenz, which is a small percentage, but a significant percentage, also got lipoatrophy. And he took out the patients who were slow metabolizers, and he actually showed that fast metabolizers, normal metabolizers, gained weight at exactly the same way as the dolutegravir patients on tenofovir. So essentially showing that it's efavirenz that's keeping you thin, not that dolutegravir is making you fat. And I think there was a similar study done in the USA. Gary was just ahead of the pack with this amazing team at UCT. And I think the whole world has accepted now that the integrase inhibitors actually do not make you fat. At the same time, there's a fair amount of data to show that tenofovir just gives you low-level gastrointestinal nausea and probably functions very similar to what the GLP agonists are doing, which just suppresses your appetite just a little enough to keep you thin. So I've got 2 patients to demonstrate to you and what we sit with is my first patient, while I was swanning it out, presenting at this Mexico City conference, we had this patient sobbing in the clinic who started off with a baseline BMI of 23. She's doing everything we told her to do. She was dieting, she was exercising, she lives in Hillbrow, so running around the block is probably going to lower your life expectancy fairly dramatically. She's now got a BMI of 44. We switched to efavirenz in the old days when we thought that would be a good idea. We don't do that anymore because we know it's a really bad idea. And she's continuing to gain weight. Still now, she's in our clinic and she continues to gain weight. She's thankfully started to sit at about 44, 45. And she's saying, what are you going to do for me? I still can't lose weight. I'm exercising and I'm dieting. We have nothing to offer her. And it's, Didi was showing us, like, you exercise this NEJM review, which is a bit dated now, but showed that you can live on a diet of boiled lettuce and exercise every single day. And if you are absolutely committed to this, you're going to, only a small percentage of you are going to lose 5% of your weight. We've been setting a bit of a lie to our patients that exercise and diet is going to make any difference to your weight loss. We've now got these amazing drugs, and surgery definitely works. And listening to Didi, I'm going to be bundling about all my patients across to her to go and help. But these new drugs really do seem to be working. And previously we've had liraglutide and phentermine and topiramate, and this new drug semaglutide recently showed up to a 15% weight loss and we're busy looking at studies to give to our HIV patients now as an alternative to as an injectable once a week to take forward. So case 2, though, is a different case. Patient also from Advance, BMI 35, and she's completely healthy. She's just big. She's got nothing wrong metabolically. She's completely happy in a relationship. She's got a happy family. And every time she goes through the door, it doesn't matter whether she's going for a pap smear or a brick fell on her toe, her doctor just wants to cure her and wants to lecture her about her weight. And she's like, I'm healthier than my doctor or my nurses, and all they want to talk to me is cure me. And Praveen talked about a cardiac paradox. There's an HIV paradox, she's just like, leave me alone. I'm quite happy with my weight. I'm happy with, you keep telling me she actually knows this data. She's scientifically clued up. In fact, we've known this for a long time. There's an HIV paradox with weight. People with HIV, their CD4 counts go down slower if they're fat, and they go up faster if they're overweight. So, again, and they're less likely to get TB. If they do get TB, they're more likely to survive. They're more likely to survive the cancer. So again, she's clued up and she's like, why would you want me to lose weight when I actually do better? So a lot of the stuff is, and she's also clued up because she knows that lots of us, we're colluding with an industry that wants to make lots and lots of money off her. So we also got to think about this, is that there are lots of people who are making lots and lots of money of us telling them that they're unhealthy when they're actually not really unhealthy. So where have we landed with weight and HIV? Well, we now know that efavirenz is not a healthy way to lose weight. That the same way they lose weight is the same thing that's making their livers explode, it's making their brains explode. It's not a good switch option. So, that is not something we're going to be doing in the future. We did do it briefly in 2019. We're not doing it anymore now. We don't know that we can switch anybody off an integrase inhibitor and get them to lose weight. And in fact, I think the world in HIV is probably going to move and just keep them on dolutegravir for the moment until we know for certain that we have a switch. I don't think we're going to find that, to be honest, just knowing what we know. We know that tenofovir mitigates weight gain probably by about kilograms. So it's very, very modest. TAF, if you move to TAF, you are going to gain weight. It's that simple. There's minimal metabolic benefits to moving to TAF. The rich countries are using it a lot. I'm not of the view that there's much benefit between the two drugs. There's a big debate about that, but we can talk about that if you want to. Some people still think that TAF makes you gain weight. There's a big debate about that as well. we need to keep ourselves busy in the HIV world. But the weight gain is significant if you start people with low CD4 counts, which is most people still in South Africa start with a CD4 count of below 30. And most people are Black, and many of them still are women. And most people are actually switch patients in our country. They started on efavirenz. So this is important for the endocrinologists and gastroenterologists there, because we're going to be referring all our patients across to you, because pretty much all of them are going to become obese. In fact, in the advanced study, almost all, as I said, 80% of the women on the TAF arm became obese, and most of the men became obese. So pretty much everyone with HIV is going to end up with obesity. That's scary stuff. So just a quick reflection for myself, because I've had to go and sit in the obesity lectures like this one for the last little while and get shouted at by obesity activists. It's been quite a schooling experience. And I think the only people who think obese diet and exercise work for weight loss are non-obesity people. And I've had to go and immerse myself in this stuff. And I'm not going to read this out to you, because I think some of Didi actually covered it quite well, is that you need to eat well. Jeff Wing was saying this to me. You need to eat well because it's good for you. You need to exercise because it's good for you, but it's not going to make you lose weight. It might work for a tiny number of people. As Didi said, it might work for a year or two, but it's not going to work in the long term. It's actually, and what was really interesting was this idea of normal values, like your weight gain. As my large patient said to me, like, why would you want me to lose weight if I'm actually going to live longer, if I've got more weight on me? So what's the normal value if actually you're going to live longer if I'm overweight? Is that really overweight? Maybe that's a good way to be. So you heard a little bit about stuff I grew up at as a registrar, talking about Barker's hypothesis. We had this amazing physiologist give a talk at CROI in that 2019 I was talking about. She said to me, well, not to me, to the group, she gave this lecture, and she said, actually exercise and dieting actually has been more and more implicated in gaining weight. Yeah, you'll lose weight in the medium term, in the short term, but in fact, all starvation states prime you for weight gain. And in fact, HIV itself might be an obesogenic state. You see it in lots of the inflammatory diseases where you actually stop the inflammation. And HIV is an inflammatory state, that when you give antiretrovirals, you stop the inflammation, and that's why your body makes you gain weight. And in fact, what we might have to do is start using these anti-obesity agents much earlier in HIV and start using them to stop people gaining weight at an earlier stage. So HIV is in a very strange world where we may have to be treating obesity a lot earlier than we thought. So this is, for me, as an HIV doctor, as I said, a bit of an existential crisis. Rather than treating skinny people with TB, I'm starting to treat people. I'm worrying about what we're going to be dealing with, which is people who are going to become obese. I'm worrying about what's going to happen to them in the future, with no real clear answer as to what is the weight that we're going to need to deal. So my final thoughts on this is, we are going to have to counsel at-risk patients, which is pretty much all South Africans, as the previous speakers have said. And as I said, we're going to have to encourage exercise and good diet, but stop linking it to weight loss, just talking about it as a good thing to do. Keep an eye on all those metabolic complications, because they're important to do. And I think as physicians, we all know that they're good things to do. I'm going to have to keep a close eye on all these debates and start to become an expert on all this stuff around obesity, which is all those ghastly endocrine pathways, which I hated as a registrar. Now I'm going to have to learn 20 years later is proving to be very, very hard, but also understand that some of these answers are not easy. We're doing a whole of sleep apnea work. There's a remarkable amount of sleep apnea in the HIV space. HIV itself is a very strong risk factor for sleep apnea, but obviously obesity is linked to that as well. And start watching these exciting drugs, and how, as I said, I'm going to be seeing lots and lots of patients to Didi's clinic in the near future. And finally, I think, I was talking about being an activist. I think for all of us, I got yelled at on one of the obesity lectures by obesity activists about using fat shaming language and stuff like that. And I think for all of us, just to be a little bit more conscious about how we behave and what we say, and colluding with the gym industry and the diet industry and all the stuff that I certainly have just done without thinking for the last 20 or 30 years, being a bit more conscious about what we do and what we say, and how we treat our patients. I've certainly talked about diet and exercise in a way I think that's quite insensitive sometimes to my patients. And just as I was chairing a session on obesity about 3 or 4 months ago, and we had a whole of HIV positive patients. And honestly, you couldn't tell the difference between physicians and doctors. It became almost like a therapy session because everyone had gained so much weight over lockdown. Because we had all, like, we were talking about what we'd done to try and stop gaining weight and all the things that just didn't work. So I think for all of us, just thinking about this a little bit more, taking 10 steps back and thinking about how we're going to deal with this going forward, because I think for, not just for HIV, but just generally for the field, this is probably for South Africa, a problem we're all going to have to grapple with and deal with going forward. Thanks very much.